of the day. So may I request Dr. Ritesh Verma, the unusual suspect, retinoblastoma. Over to you.
So very good afternoon, everyone. So I'll be talking about enigma of a case, which is a 22-year-old male, which presented to us for a second opinion. Can you? Okay. So just to give you a context, he presented with a gradually progressive painless blurring of vision from the past 2 months, which was associated with floaters. So he came for a second opinion after he was advised the vitreous biopsy, and he was advised intravitreal antifungals with antibiotics. And there were all sort of diagnoses on the previous slips. It was a tuberculoma in some or a choroidal abscess, and he underwent these battery of tests. So on examination, the visual acuity in the right eye was 624 N36, and the left eye it was 66 N6. The pressures were normal, and the anterior segment was unremarkable in the both eyes. So on posterior segment, you see there is a tortuosity and dilatation of the vessels in both superior and inferior quadrant. You see this some yellow subretinal deposits, and you then see some floating white vitreous spheres. So on wide field imaging, you can see there is a large mass in the periphery, which has a subretinal component, which has an epiretinal fluffy component, and there are multiple floating vitreous spheres. So on B scan, you can see there is a corresponding hyperreflective mass, which has, you can see both the epiretinal and the subretinal component, and the vitreous component as well, and there is a little subretinal fluid. So at this point, our diagnosis was whether it's an adult onset retinoblastoma or an amelanotic melanoma. So points in favor of the retinoblastoma was that there were multiple subretinal and vitreous seeds, and it has a moderate to high internal reflectivity. So we diagnosed it as a group D retinoblastoma, and we went ahead and do an OCT scan, which showed us the same, the subretinal as well as the epiretinal spheres, with a minimal subretinal fluid in the macula. The anterior segment was normal on the AS OCT, and on MRI you can see there is a region which is hyperintense on T1 and hypo on T2. The optic nerve was normal. There was no intracranial extension, and there was a minimal contrast uptake. So at this point, we offered the treatment plan to the patient, and we went ahead and did enucleation in this patient because this patient was from a far off place, and he did not want to come back for the multiple sessions of chemotherapy. So we were not really sure what to do in this case, so we went ahead and did an enucleation. After enucleation, you can see on histopathology, it was confirmed it's a round blue cell tumor, and IHC was positive for synaptophysin and chromogranin A, and there was a high KI 67 index. There were no high-risk features. So what makes this case challenging is, number one, the pathogenesis. So there are two possible explanations for retinoblastoma in an adult patient is whether there was persistence of some embryonal retinal cells, or it was a spontaneously regressed or arrested retinoblastoma which was reactivated. So this is another patient of a retinocytoma or a spontaneously regressed retinoblastoma, wherein you have this area of calcification as well as some atrophic retina. So we did not see this in our patient, and there was no family history as well. So we diagnosed it as a de novo retinoblastoma from persistence of embryonal retinal cells. So another challenge was the misdiagnosis. There are 35 odd cases which have been reported earlier, and there are all sorts of misdiagnosis. Another thing is the classification, the ICRB, which has been proposed for the retinoblastoma classification. It is only for the children, not for the adults. So whether these treatment options and classification is valid on the adults, we are not really sure. And there has been one large series by Dr. Swati Kalki, in which only there was one globe salvage in isolated 30 cases which they presented in the study. So there are a lot of unanswered questions regarding the genetic makeup, the globe salvage, and the long-term survival of these adults. So we don't really know what to call this case, a retinocytoma or a retinoblastoma. So this really makes our case a challenging and a rare scenario. Thank you.
I have described three cases of adult onset retinoblastoma in survey of ophthalmology with review of literature, and the oldest of that was 32 years old. It's really a diagnostic challenge when you see a retinoblastoma in adults. Whether they start from a retinocytoma and then missed, and then at adult age they develop retinoblastoma is not really known. But this is a unique manifestation of retinoblastoma. But there are around 30 to 40 cases has been reported in the literature.
Yes.
3 cases by my.
Even sir, that one of our patient who ultimately went to you, that lady, we are following her for almost last 15 years. We have done an enucleation, like we were in a diagnostic dilemma, it was sent to sir. Then ultimately, sir, you all had done a vitreous biopsy.
Yeah, we did a final aspiration biopsy.
FNAC was done, then ultimately she was enucleated, that I was enucleated, and no no chemo was given because it was not a high-risk retinoblastoma. It was just I think retinocytoma. That was what you all feel, no? Retinocytoma converting into a malignancy. And she is with me for the follow-up for almost 15 years, and she's fine. Otherwise, she is doing very good. But I feel that I have seen 2 cases only till now, and both are females. So is it that it is more common amongst the females, or sir, what is your thought?
I have got a one male patient also. The female is, I don't think there is a gender variations, but the thing is how it has been, I don't think that it's from the childhood retinoblastoma growing in adult. I think it's a kind of some retinoblast cells is there which grows into that in adult stage, or from a retinocytoma which is missed and which is asymptomatic and later on developed retinoblastoma. So if they come with a vitreous seed at this age, this current scenario, I want to really enucleate. I will try the chemotherapy.
Yes, yes, sir. Yeah.
We have also reported one case of adult onset retinoblastoma. In that case, we have done blunder. Basically, patient has given history of trauma, and we thought patient has panophthalmitis, so we have gone for evisceration. But during evisceration, it was found that there's some mass-like feature. So we have sent for histopathology, and it comes out to be retinoblastoma. It has been published in, patient was around 27-year-old male. It was published in Orbit.
Have you done a vitreous biopsy or?
No.
Before
that
I'm asking.
We didn't do a vitreous biopsy initially.
But you saw vitreous seeds. You could have done a aspiration biopsy.
So because we were thinking of retinoblastoma, we were not really sure whether it will lead on to extraocular spread or not. So if we are thinking on the lines of retinoblastoma, you can go ahead with the ice ball technique, the same technique we used to inject in retinoblastoma kids. But we were not really sure at that time. So the patient already, he wanted enucleation. So we went ahead and did enucleation in this case.
Yeah, excellent case presentation. Retinoblastoma is something very dear to my heart. Yeah, so 2 things here. Like whenever there is a vitreous seed, adult onset retinoblastoma is very, very rare. All right. Whenever you find a whitish lesion and there is vitreous seeds, it's almost always retinoblastoma. So melanoma doesn't present with white seeds. Another thing that in adults that we should keep in mind is lymphoma, or even leukemia. But lymphoma, again, you don't get this large lesion, and you had, hyperreflectivity in the ultrasound. Yeah. So I don't think there is a diagnostic dilemma here, clinically. Now, when you talk about medulloepithelioma, which is yet another differential diagnosis, we call it as ciliary body medulloepithelioma, right? So most of these lesions are in the periphery. And when seed happens in ciliary body medulloepithelioma, it's usually in the anterior segment. Their presence with sago grain seeds in the AC, anterior chamber, not really in the vitreous. So vitreous seeds is mostly retinoblastoma, if not lymphoma, or very rarely leukemia. So that is how. Now, regarding the classification, that you actually used a sentence that the classification of retinoblastoma is for the children, which is wrong. Okay, retinoblastoma, although it is very, very common in children, it can happen in adults, which is the oldest patient in the case report, if you have done a review of literature.
So I think it was a 55-year-old.
Yeah, so 62-year-old by Shields from Wills Eye Hospital. So the classification remains the same. Okay. Now that we have the TNM-H classification also as any other cancers in the body for retinoblastoma, so classification doesn't change for a child or an adult, all right? Yeah. And as Dr. Biswas clearly mentioned, we have so much of advancement in treatment of retinoblastoma. It was in fact a very small lesion with vitreous seeds. We should be able to counsel the patient for chemotherapy and vitreous seeds, and treatment remains the same universally, worldwide, for an adult or a child. Depending upon the body weight and age, the dosage changes, but the treatment doesn't change. Thank you.
So for that statement, whether this ICRB classification, leads, the prognostic classification is same for the adults as well, that will, that's the point. The prognosis, whether it remains the same in adults.
Well, so every tumor behaves in a different way. Even in a child, not every tumor, behaves the same way.
I think for the final established diagnosis, either you should have done a vitreous biopsy for histopathology, or you should have gone for genetic analysis to establish that, yes, this is retinoblastoma only. I think clinically it is appearing, I agree.
So vitreous biopsy probably not, because clinically it was a clear shot case of a tumor with hyperreflectivity and vitreous seed.
How are you sure? Even the lymphoma can have vitreous haze, it's true. But lymphoma can also have a vitreous, it will present as a white lesion with some of vitreous cells. But I still believe that without a biopsy, sir, should we start any treatment? What do you
I'm
say?
not in favor of giving treatment without biopsy. Cytopathology.
So in this case, probably there was hyperreflectivity in the ultrasound. That means there is some calcification there. And it's a tumor which is like very typical of a white lesion with vitreous seeds and subretinal seeds also, which they, you know, in OCT it was proven. So I personally wouldn't go for a biopsy. I mean, it's just my personal practice, yeah.
So we discussed
I
all
know
the
it's
options.
99% retinoblastoma.
So we discussed all the options with the patient, and finally he agreed for enucleation. So we went ahead with enucleation.
You have gone for enucleation.
Yeah.
Huh.
For that, then definitely you should have gone for histology of the enucleation.
So we did histopathology, sir.
Huh,
It
then
came
we
as-
had done,
it
but
came as
before that, I think the
retinoblastoma.
globe could have been salvaged in case you had done very aggressive treatment, because now to 95% salvage rate, they say, right?
Yes, ma'am, yeah.
The patient
with
did not
vitreous.
agree for follow-ups. He did not want the side effects of chemotherapy. So he wanted.
Anyways, all the discussion, all the, right, but what I still believe, what Bishwas sir has mentioned, we should have a confirmatory diagnosis in any cancer. Because cancer is not an eye treatment, it's a treatment of the life. So we need to have a confirmatory diagnosis when that is what we practice. But there's always individual variations.